If you could take your seats, please, ladies and gentlemen. Dr. Galotta. Welcome, delegates. Welcome to Canberra. Welcome to the 2014 National Conference from AMA. The title of the conference is Global Practice from an Australian Perspective, so we were hoping to look at Australian work in the region and how the region interacts with Australia. For this rather procedural section of National Conference, you'll need your voting delegates cards, and the quorum for the meeting is 50%, and I've just flagged that for the urgency motions it'll be a 2/3 majority to pass those. I'll begin by thanking the sponsors. The meeting has been generously sponsored, and you'll see that there's no trade display, but we have a generous sponsorship from our platinum sponsor Telstra, from Macquarie Leasing, who's a gold sponsor, from Amex, who's the communications sponsor. Avant is sponsoring the leadership dinner tonight, and Volkswagen and OnePath are both conference sponsors, and sincere gratitude to the support they have for the National Conference. I'll just turn to a practical matter, which is the Wi-Fi. We have put in a special, very high-speed and reliable Wi-Fi which sits on top of this conference centre's Wi-Fi. And when you look for Wi-Fi, you choose NCC, National Conference Centre Wireless, and then you come up with this page and you don't fill the box in. You choose the little box on the top at the right that says click here, and with that you will go to a second, much faster and reliable system, and the entry is AMA delegate as one word, all lowercase. And through that you can put your questions to each of the plenary sessions. When you come to the questions, you need to put your name, the email is optional, and the question is down below. Use the click here, you'll be on for the day. Don't use the other one, which is slow and cumbersome. The other thing I've been asked to remind you is that the Twitter tag, which is very active already for National Conference, is #AMANC14, AMA National Conference 14. So it's #AMANC14. So that comes to the business of the conference. The first item of business is the notice of conference, which was published in the Medical Journal of Australia on the 7th of April 2014. And so I'll move from the chair that the notice of the 2014 National Conference for AMA Limited be taken as read. Is there any dissent? I'll put the motion, a show of hands. The motion's passed. The next thing we need to do is the accreditation of delegates. And according to the Standing Order 6 of the National Conference, no business can be transacted unless at least half the number of delegates eligible to attend, and if not a whole number, the next number of delegates is present. The number of delegates we have is 153, and so we need to have 77 delegates, and I see that that is the case. So I'll put to the meeting that the list of delegates present to be noted for the purposes of accreditation of National Conference delegates be accepted. By a show of hands, I put the motion. I declare the motion passed. We have to adopt the standing orders for National Conference, and you'll see these all reproduced in page 12 of the handbook that you have. So I'll put to the meeting that the standing orders for National Conference as circulated be adopted. Again, by show of hands, the motion's passed. We need to adopt the agenda for the 2014 National Conference, which is circulated with the conference papers and is found on pages 5 to 7 in the handbook and also on the web. So I'll put the motion that the agenda for the 2014 National Conference as circulated be adopted. Again, a show of hands. I declare that passed. The minutes of last year's National Conference have also been circulated in the handbook, and you'll find those on page 27. So I'll put to the meeting that the minutes of the 2014 National Conference be taken as read. Is there any comment on the previous minutes as circulated? So I'll put the motion by show of hands. Those in favour? And I declare that passed. In relation to the 2013 National Conference minutes, there were no specific motions that require a specific report in this conference papers. Are there any matters arising from those National Conference minutes that need to be raised now? None? And the last order of business is the National Conference or motions on notice. There were no motions on notice that were received within the specific period, which is 8 weeks before National Conference. But we do have 2 urgency motions. Urgency motions are received up to 1 o'clock today, and they relate to matters that delegates feel are urgent and require debate, and it's a 2-stage process. Now we will see the urgency motion and decide whether this is urgent, whether this is worthy of debate. And the proposer of the motion has 2 minutes to explain to delegates why this should be debated. If you choose that it is urgent and should be debated, it will be debated tomorrow afternoon as a substantive motion. So the first motion, which we need on the screen, please. The first draft urgency motion is proposed by Dr. Xavier Yu and seconded by Dr. Stuart Day. So I would invite Dr. Yu to come forward for 2 minutes to explain to us, come to the lectern, 2 minutes to explain to us why the motion should be debated as a matter of urgency.
Thank you, Chair. Fellow delegates, I commend this motion that you see on screen as an urgent one, which warrants timely debate in this year's National Conference. As you know, the AMA opposes task substitution, where practitioners independently undertake tasks usually undertaken by doctors. The AMA supports role delegation, where duties are performed by non-medical practitioners but are under the direct supervision of a doctor. Programs to expand role substitution are on the current and near horizon. The Grattan Institute this year claimed in a report that specialist nurses could free up doctors' time by doing common low-risk procedures now done by doctors. And the Federal Government's Commission of Audit recently has also similarly recommended extending the scope of practice of other health professionals. These 2 reports arise on a background of what you've just heard earlier today from Minister Dutton, who claims to want to strengthen primary care, but with more non-medical practitioners, such as physiotherapists managing musculoskeletal disorders in emergency departments, and in the community with minimal medical input, pharmacists performing health checks, and likewise for optometrists in managing glaucoma. This National Conference is your opportunity, fellow delegates, to send a clear and timely message to AMA Federal Council that we want our organisation to be more proactive in identifying and scrutinising such role substitution proposals from state and federal governments. This increasingly more prominent issue has to be addressed by Federal Council as a matter of urgency in light of such developments. I move that the motion proposed be debated as a matter of urgency in the absence of notice and preparatory material. And finally, I thank Dr. Stuart Day for kindly agreeing to second this motion.
Thank you, Dr. Yu. There's no debate on that. I put the motion that Dr. Yu has just repeated. So by a show of hands, whether the motion behind me is a matter of urgency to be debated by National Conference tomorrow. You need a 2/3 majority. We have a 2/3 majority. The motion is passed. The second motion of urgency comes from Dr. Lorraine Baker in Victoria, seconded by Dr. Leon Massage. There's the motion behind me. Dr. Baker. 2 minutes to explain why this is a matter of urgency. Not the motion, the urgency.
This is urgent to me. The use of language in the way we have a dialogue with our members and with the public and with politicians is very important. The co-payment is a fee that my patients pay to me when they see me in a private billing consultation. I run a private billing practice. My patients are already paying a $40 co-payment to me when they see me for a standard consultation. Now they are going to be asked to pay a $5 tax. Not only that, the patients I bill directly to Medicare who are indigent, who are needy, who have become unemployed unexpectedly, will now be paying $7, $5 of which is a tax, and $2 will be paid to me as an administrative fee. This is a tax. I agree with the Labor Party in naming it a tax. I don't agree with their position. This is a rejection of the value of general practice. I refuse to have the value of general practice diminished further by government that in the past governments has devalued general practice, and now it's happening more. We need to call this a tax when we're in dialogue with government. It is not a payment to GPs. GPs are becoming a de facto tax collector with increased administrative costs and a risk to them of patients failing to attend and the actual disruption of the doctor-patient relationship. I commend my motion to you.
Thank you, Dr. Baker. So the motion before us is that this motion of Dr. Baker and Dr. Massage be debated as a matter of urgency in the absence of notice and preparatory material. Those in favour? Those against? The motion is carried. So thank you, ladies and gentlemen, for your indulgence in the process of the meeting, National Conference, and for the urgency motions. And we come now to the first plenary session to be chaired by Professor Jeff Dobb.
Good afternoon, ladies and gentlemen, and welcome to this first plenary session of the AMA National Conference. Just want to inform delegates that this session is now open for you to post questions using the question system that is available through the internet link that the Chair of Council described to you just now. So this first plenary session relates to the theme of global health and is about the epidemic of non-communicable diseases. Now, as we heard this morning from the Ambassador for the United States, the main focus of bodies such as the World Health Organization and indeed the World Medical Association has for many years been on communicable diseases and reducing the incidence of those, particularly in the more disadvantaged nations of the world. But what we're seeing now, not just in the developed world, but also in those countries, is an increase in the diseases that are associated with such things as tobacco, alcohol, lack of exercise, obesity. And we have a great panel of speakers here this afternoon to address the issues associated with this epidemic. So, first speaker I'd like to invite is Professor Rob Moody, who is going to address us on the global context of non-communicable diseases and Australia's involvement in the Asia-Pacific region. Professor Moody.
Thanks, Jeff, and thank you very much for the opportunity of speaking with you this afternoon. What I'd like to do is I'll be focusing mainly, just as Jeff mentioned, around sort of the four big groups of non-communicable disease: heart disease, diabetes, cancer and chronic lung disease, and their associated risk factors. Harry Minnis is going to be really addressing one of the other, obviously, huge areas of non-communicable disease around issues relating to mental health and mental illness. And Mike will be looking at specifically around these issues in Australia. These are big issues, as Jeff was mentioning, and they're, in a sense of their scope. I guess we're well behind the eight ball in many ways. The fact that if you just look at the toll globally, whether it's around tobacco, whether it's around alcohol, where the major killers now, and the huge number of, for example, people with diabetes, then these are big issues. There's a big shift in the global burden of disease. If you take the work that's done by Chris Murray and Alan Lopez looking at the global burden of disease, they measured it in 1990. They've done incredibly good work in following this up 20 years later and seeing pretty major shifts, as Jeff mentioned, away from in a sense we're doing a better job with infectious diseases, with communicable diseases, but in terms of looking at these big issues around non-communicable diseases, then globally these are becoming the big issues of our time. If we just look at obesity, for example, then in many countries you'll see the fact that in many developing countries, to take the bottom one or the bottom two, in fact bottom three, Egypt, Samoa and Tonga, really high levels of overweight and obesity, and this is amongst women. It's also reflected in men as well. That's about where we are, and you can see these other major problems. Now, it's not whether it's developed or developing. You can see some very high. The Netherlands much lower rates than we have. Japan much lower rates than we have. We're sort of not doing so well in this area. This is why these are global problems. They're not sort of individual national problems now. And as we'll show, if we want to solve these issues, or in fact do better, then we will need combined global solutions. It won't be a question of one country just being able to hold out on its own. Again, if we just take the Southeast Asian region also, so not only is this affecting developing countries, but it's affecting them in a way where they're dying much younger from the same diseases than we are here, for example. And if you look here in the Southeast Asia region, then if you're looking at all NCDs or cancer, then the premature mortality rates are much higher in the Southeast Asia region than they are either in the rest of the world, or if we compared it to they'd be in fact much lower rates if we looked at high income countries more generally. So these diseases are affecting developing countries in such a much more serious way than a sense they are in even places like Australia. Now, what's been good, I guess, in the last few years, there was a high-level UN meeting in 2011, the second time only that the UN's actually looked at a disease and taken it, as a sort of General Assembly issue. The first was HIV in 2003. But this is when all the countries came together and said, well, these are big issues. And out of that, at least we've been able to set some global targets. The biggest one being what's called 25 by 25, a reduction of premature mortality by 25%, and it's by the year 2025. And we look here, these are all reductions of risk factors around tobacco, around alcohol, around hypertension, around salt intake as well, around physical inactivity, as well as two major goals around access to treatment. As we'll see, this is, as it has been with issues like HIV, a major problem where, in fact, the treatment's not all that expensive, but it's just simply not getting to people as it should. And if you look at what's going on at the moment, then it's not actually a technical failure that is preventing us from effectively dealing with these issues at a global level. It's much more a political failure, that action is inadequate nationally by development agencies and even by some of the foundations, although I must give credit to people like Bloomberg and Gates Foundation that are finally starting to invest in issues like tobacco control, and that should be celebrated. But as I'll show, the amount that we spend, for example, in development assistance in health on NCDs in the developing world compared to what we spend on HIV is minuscule. And not that I want anything less spent on HIV, but just that we're completely missing the boat if we do substantially want to prevent enormous numbers of premature deaths. What's also happening is that there are drivers of these diseases, and as Mike will be talking a little bit later about it, the fact that these are, in a sense, what you might call, some people call them lifestyle diseases, and that's true to a certain extent, but they're also industrial diseases. They're driven by what you might call industrial vectors, and this is the tobacco companies, the alcohol companies, and the ultra-processed food and drink companies. And what's happening is that they're expanding rapidly into the developing world at a very, very fast rates. Not only are they seeing sort of saturation level of activity in the developed world, but they see enormous, read their annual reports, enormous scope for development in the developing world. And if you just look at sort of the growth of markets in the last sort of 10 or 12 years between 1997 and 2009, in low-income countries and compared to high-income countries, then take tobacco, for example, not much growth in high-income countries, major growth in low-income countries, similarly around alcohol, but also in terms of packaged food, soft drinks, oils and fats, snacks and snack bars. This is where the money is. And unfortunately also, these are countries that are least well regulated, that have least capacity to actually manage the work of these what we would call unhealthy commodity companies. North of us, one of the single most worrying things that troubles me about global health, 40% of 13 to 15-year-old Indonesian boys smoke, 67% of men. That is one of the biggest train wrecks on its way in terms of premature death, in terms of reduction of productivity, entirely preventable. The problem is, of course, who's doing it? Well, of course, Philip Morris, who obviously very active in Australia and active internationally, have set themselves, they bought the national tobacco companies in Indonesia, and they've set themselves up in a way that they've actually said, okay, Indonesia is the centre of our Asia-Pacific activities. Now, they're dealing with a product they know, if used as directed, will kill 50% or more of its users prematurely. They know this. They know it's addictive. They know it's chemically addictive. And yet they are willing to and will continue to expand their operations in this part of the world. We've looked at, a number of my colleagues have looked at what do these companies do, how do they operate? In particular, if you look at the alcohol and the ultra-processed food and drink companies, and you look at the way that they operate compared to the tobacco companies, and we see huge similarities. The fact that they're prepared to bias research findings, co-opt policymakers, lobby politicians and public officials very strongly, influence voters, and blatantly ignore their own codes of conduct. Just some examples. In the tobacco area, they set up Project White Coat, was really to buy doctors out or buy researchers out. We see the International Centre for Alcohol Policies, who produce reports that look just like WHO reports, but they always emphasise a high disagreement among scientists or supportive of industry positions. So the use of front organisations is a way of, in a sense, hiding what you're doing and making it appear to the public that this is science-based evidence. Interesting studies recently. One is looking at meta-analyses of the effect of sugar-sweetened beverages and its association with obesity, then if your study is funded by the sugar-sweetened beverage industry, then it's 5 times more likely to have a finding that is industry positive than if it's not funded. And similarly, we've seen that with processed food companies as well. So what we really do need to know is who's funding this research, who's doing it as well. If you look at co-opting of policymakers, again, setting up things like the US Tobacco Institute, there's a wonderful example in sub-Saharan Africa where SAB Miller, which is one of the biggest, if not, I think the biggest alcohol firm globally, they offered, and in fact used an Australian consultant to our shame, to help 4 sub-Saharan countries write their alcohol policies. All the policies were pretty much the same. They all completely ignored the evidence base that was actually there from WHO and other organisations, and in a sense focused on strategies that simply didn't work. We have our own Australian Food and Grocery Council, who very cynically introduced their own self-regulation code around advertising to children at the time of the National Preventative Health Task Force. Of course, what their code does is about when children, it's for children's viewing times, which is of course when very few children actually watch television. Children are watching television during adult viewing times, and that's when they're, in a sense, being saturated with junk food and junk drink advertising. And as Mike Daub has very eloquently shown time and time again, it's often the same people that move, in a sense, from tobacco companies to alcohol companies to junk food companies. So they're using the same methodologies, same advertising and PR agencies as well. Lobbying politicians, then the enormous amount of money that's actually spent by alcohol companies or by sugar-sweetened beverages companies to actually focus on targeting in the US congressmen and senators who are supportive of their positions. Some of you, I hope, will have seen last night The Men Who Made Us Fat. If you haven't, then look at it on iView on ABC. It's a fascinating view of how, in a sense, what's generated the obesity epidemic globally. And what they were talking about last night was the threats of the sugar industry on WHO to block their funding. If this is about 10 years ago, if they were to introduce guidelines around reduction of sugar. So they're not short of a capacity to threaten, cajole, and strongly influence politicians. We have in Australia, obviously, the Australian Food and Grocery Council, the Australian Hotels Association, extremely powerful, well-connected, and very strong lobbyists. And we know that when we would see a minister, that before us and after us, they will have been there. And their capacity to influence policy that we think fundamentally they should not be discussed. In a sense, health policy is not their bag. Their bag is economic policy. That's fine. It's industry, but in a sense, they shouldn't be around the health policy table. Influencing voters to oppose public health regulation, obviously a huge amount, and Mike will show this what's happened in Australia. They'll fundamentally focus on anything that's against any form of regulation or taxation. And the other thing, of course, is to get everybody to look somewhere else. So all the sugar-sweetened beverage companies and ultra-processed food companies will say, well, let's focus on physical activity. Now, that's not wrong, but it's a point of saying, well, look, we don't want you to focus at all on junk food or junk drinks, just look at physical activity. So look the other way. We've seen this in tobacco, for example, where they've funded domestic violence campaigns simply to appear to be using their corporate social responsibility approaches to deflect criticism. They'll also blatantly abuse their own codes. I love this one in the right corner. I don't know if you can actually see it, but it's basically an advertising code which is about for alcohol, which is to use no explicit sexual imagery. I mean, highly cynical approaches to doing this. And if you look at Coca-Cola, it says never ever markets to kids as part of the obesity solution. Then download Santa's Helper, an iPhone that they've produced. And I just want to show you this next this next campaign done by Coke, just to show you how good they are, and in a sense, what you're dealing with as a doctor. When your patients, you counsel them around weight, you counsel them around sugar intake, you counsel them around intake of sugar-sweetened beverages, and this is what they get.
Last September, in the dead of night, the world's most iconic brand did the unthinkable and took an entire country by surprise. 150 of Australia's most popular names appeared on millions of bottles of Coke. Why? Because in the previous month alone, 50% of teens and young adults hadn't even tasted a Coke. We had to reconnect with Australia, so we decided to get personal. The internet blew up straight away, but we kept quiet. And while the buzz grew and grew, we recruited our fans and made them the face of our campaign. Then, on Australia's highest rated media weekend, we came clean and invited Australians all over to share a Coke.
Kate and Kate, the two Kates. Classy Kate. Crazy Kate. If you know a Kate, share a Coke with Kate, or Mel, or Dave, or Jane, or Ash.
Our message was everywhere, digitally and interactively at Sydney's iconic Coke billboard. Whichever way you turned, it was you and your friends up in lights. The media instantly took notice. Blogs lit up. Australia had fallen in love.
Coca-Cola.
Sharing a Coke.
Thousands of requests poured in for more names, but we were ready. With kiosks where you could get any name printed on a Coke can. People couldn't get enough, queuing for hours. But the requests kept flooding in. So we put it to a vote and asked Australia who they wanted to share a Coke with most. And after 65,000 people got their say, 50 new names were released. We invited everyone to share a Coke, and share they did. Whether old or young, drinkers or non-drinkers, friends searched for names, tagged one another, shared stories. Australians everywhere were once more connecting over the world's most iconic brand. And with the holidays looming, we celebrated and shared a Coke with a friend who brings a smile to every face. In just 3 short months, 5% more people were drinking Coke. Sales transactions grew by 3%. Volume increased by 4%, and 870% increase in Facebook traffic. 12,020,000 earned media impressions, 76,000 virtual Coke cans shared, 378,000 extra Coke cans printed at kiosks, and one country painted red. With one simple tweak to a label, Coke once again became part of popular culture.
Thank God for Coke. Not only do they bring happiness to us, Cadbury's bring us Joyville, and in fact McDonald's last year even brought us summer. But we're grateful to them, and it is interesting that comparing the fight that we're having in a sense with the influence of these companies. I was reading Ross Garnaut's comment around climate change and the energy companies, and it is trench warfare. And I think we're moving into the same issues here. If you haven't read it, then have a look at Michael Moss's book on salt, sugar, fat, how he's focused on how the companies have actually done such incredibly good work to find out what's the right crackability of a crisp that gives you maximum sort of habituation so that you will continue to eat crisps. I mean, the amount of research that's gone into working out how we can continue to buy even more and more of products we don't necessarily need, it's both fascinating and shocking at the same time if we only had those resources in public health. If you look at what the WHO is now saying, and Margaret Chan, who's the head of WHO, saying it's now not just big tobacco, but it's big soda, big food and big alcohol to worry about these industries that fear regulation and protect themselves by using the same tactics. And as we can see, market power readily translates into political power, and few governments prioritise health over big business. So the question of how we deal with this and how you actually deal with the huge capacity of business, these businesses, not other businesses, is of huge challenge. But there is hope, and as we've seen with tobacco, we can manage some of these things very well. What we do know is that if we did, for example, around tobacco use, this is just looking at the cost per person for these interventions in China, India, Russia, very cheap at a population level, reducing salt, cardiovascular risk reduction, then these actual interventions are not expensive, hugely cost effective. If we looked at sort of cardiovascular disease interventions, then if you put up large increases in tax, we're in fact working with a number of countries in Southeast Asia to do this, then this is the best way of reducing consumption, is by increasing pricing and doing it by using tax. At the same time, smoke-free regulations and effective mass media campaigns, many countries are in fact using the campaigns that have been very effectively developed and researched in Australia. Similarly with alcohol, then similar sorts of approaches, same with diet and activity. These have less evidence around them, but in a sense we will probably find out in another few years they'll be just as effective. Recently, an article by Robert Beaglehole, and I just want to acknowledge his work from New Zealand, looking at the contribution of sort of 6 risk factors to achieving this reduction in mortality. And so it's tobacco, alcohol, blood pressure, salt, obesity and diabetes. And if you use a sort of a business's approach trend compared to one which was really intervening around these issues, then we can see from here in men and in women, if we want to get down to the 25% reduction in mortality, if we can effectively intervene around those 6 risk factors, we'll get very close to that target. If we in a sense do better in tobacco, we'll actually hit both of them. It's a huge challenge, but it's certainly not impossible. If we did that, whether it's looking at cardiovascular disease or non-communicable diseases, then the deaths prevented in the 30 to 59-year age group is actually huge. And this is about investing in productivity. It's about, in a sense, not only saving lives, but increasing productivity as well. The other issue is that globally, we simply are well behind the mark in terms of how much we would want to invest in preventing these problems compared to other issues that we should be investing in. And for the first time ever, the International Health and Metric Group, Chris Murray's group in Seattle, funded by Gates, actually measured how much we invest in tobacco. 68 million for something that is currently dealing with 1 billion smokers, then it's not very much. It's 1/100th of the amount that we're actually investing in HIV. I don't want any less invested in HIV at all, but because I think we've done very successfully and we'll continue to do very successfully there. But we obviously need a lot more money, I think, invested in tobacco control because we know what to do. We know what works, and we know, in a sense, how to take on the tobacco companies where we've got enough resources to do so. But there are big gaps in donor funding when it relates to virtually all of the non-communicable diseases. So we need to influence our own aid agencies. That's going to be a big task in Australia over the next few years, but not impossible. We also need to influence our own international development NGOs. When I was lucky enough to work in HIV in the late 80s and early 90s, and for quite a considerable length of time, we spent a lot of time trying to get all the AIDS agencies working so they knew about and understood development and worked and could work in the developing world. At the same time, we spent a considerable amount of time working with the Oxfams, the Médecins Sans Frontières, the World Visions of this world to get them interested in HIV. And because they did get interested in HIV, that's why the advocacy has been so strong and this merger of sort of collective interest. This is what we need to do in the area of NCDs. We've yet to do so. And obviously we need to increase national government investing in the Pacific. What was then AusAid, DFAT, has spent a considerable amount and focused a lot on NCDs in the Pacific. I hope that continues, and it will have to. It's the biggest killer by a long way in all the Pacific Islands, but also they're becoming major problems, obviously, in other parts of our region as well. There's also hope. I mean, there's a global social movement called NCD Free, which has been started by two Melbourne brothers who are starting to develop a campaign, really specifically run by young people. And this is what we will need to get anywhere near, I guess, how well we've done with HIV. And just to show what we're trying to do at a global level, the story of you're sitting by the river and you're watching someone come down and they're drowning, and so you pull them out and you save them, and you save them again, and then the same thing happens again. You jump in and you drag them out again, and they do it again. So what do? You go upstream and you stop people pushing them in. And that's what we have to do, I think, as a globe, is to go upstream and find out who's pushing them in and stop it. So we have to be the fence at the top of the cliff, not only the ambulance at the bottom. And to finish, I guess it's an appeal to the we need you to show you how important doctors have been in walking upstream, if you like, and stopping people being pushed in or being the fence at the top of the cliff. And just some examples, whether it was Nigel Gray, who has been one of the major architects globally around tobacco control, whether it's on his John Birrell, police surgeon in Melbourne, who together with Gordon Trinker, who was an surgeon, these are the ones who led the campaign for road trauma reduction, where we're now seeing, because of what they started in the 60s and 70s in Australia, we're probably seeing about 60,000 people who haven't died from prematurely from road trauma, 600,000 to 700,000 people who haven't ended up in long-term care because of serious injury related to road trauma. They've helped us change our culture of driving. Or whether it's Robin Marks, who was a dermatologist who really was the man behind the Slip, Slop, Slap campaign, or whether Fiona Stanley around childhood diseases. These have been, in a sense, the major voices. This is where you, as doctors, and as an organisation, I want to pay tribute to Steve Hamilton, who's done a wonderful job on the Australian National Preventative Agency's Alcohol Advisory Committee. But as a group, you have a major voice in the health of Australians. You have a major voice in helping us as a community to go upstream. The more that you can do that, the healthier obviously your patients are, but the more that we can actually then spend money in more appropriate places. Thank you very much indeed.
Thank you, Professor Moody. I think that really set the scene for this session, and thank you for that. Of course, non-communicable disease isn't just physical disease, but it's also mental health issues as well. And I'm pleased to welcome Professor Harry Minus. Associate Professor Minus is the Head of Global and Cultural Mental Health at the Centre for Mental Health in the Melbourne School of Population Health. So pleased to welcome you here to talk about mental health in the global arena and the impacts close to home.
Thanks very much, Jeff. It's a great pleasure to have the opportunity to come and speak with you this afternoon. I'm grateful to the organisers for inviting me to do so. I think the way that Rob has started this is fantastic. The problems that are being discussed of a massive scale in Australia certainly, but to some extent even more so in a number of the countries that we refer to variously, sometimes developing countries, sometimes low or middle income countries. essentially countries where there are a number of very serious obstacles to actually dealing with some of these major problems of non-communicable diseases. And mental health has been a very small part of that effort until very recently, but things are now beginning to change. Say a couple of words about this term, global mental health. It's a relatively new term. It's clearly part of global health. It's part of public health. It used to be referred to as international mental health and a number of other words. But I think the point that Rob made, that when we're talking about these issues, they are truly global. The problems are very big in low and middle income countries, but the problems are also enormous in vulnerable populations in rich countries. And I think that's what makes these issues that I'll be briefly talking with you about truly global. And so some of the work that we do links together both the global aspects of this work and a particular focus on some of the vulnerable communities in Australia. Our focus is on immigrants and refugees and on asylum seekers. And many of the issues that apply to poor populations in places like Indonesia and Vietnam and Laos also apply to some sections of our population. The situation of Indigenous communities is very well understood. I think the sort of problems that exist in some other vulnerable communities in our own country are not as well understood as they might be, and the efforts to deal with them are not as great as they might be. Some of the overall goals of global mental health are the same as global mental health in general. We're interested in a population health focus. We're interested in the social and other determinants of health and illness. We're very keen to see advances like universal health coverage, the work that's being done not only in the region but in other parts of the world, in Africa and so on, is also very much focused on health system strengthening. And one of the things that's becoming very clear, and I think Rob's talk illustrated this enormously well, that the problems are largely not technical problems, as Rob said. They are problems of political commitment and problems of investment. The goals of global mental health over the past few years have focused on mental health system development, on developing at least basic community-focused mental health programs where they haven't previously existed. They're also very much focused on human rights protection, because of the incredibly high prevalence of human rights abuses of people, particularly people with severe and persisting mental disorders, and that's been an area where we have focused a good deal. And the final area, I think the final broad area of focus, is how good is our evidence for the development of policies and programs and services. And I think over the past 10 years or so, the evidence base for some of the mental health system development that's happening in Asia and in other parts of the world has been brought together in a much more compelling way than was previously the case, and has been marshalled and communicated, I think, in ways that have increased the level of attention to mental health as compared with 10 or 15 or 20 years ago. I think there are a number of issues that have contributed to this increasing attention to mental health, particularly mental health in low and middle income countries. One of the most important, I think, was mentioned by Rob, the Global Burden of Disease study in 1990. I think prior to that study, mental health, mental disorders were almost invisible in the developing world. And I think there was widespread surprise at how much disability can be attributed to mental disorders, mental and neurological disorders at that time. In the repeat of that work, the 2010 study, which was published in 2012, some of the figures have changed because some of the methods are a little different to the 1990 study, but they are broadly similar. And a very substantial proportion of particularly the disability burden can be attributed to mental disorders, particularly in that part of life which is the most productive, from late adolescence through to young and mid-adulthood. So the GBD work has been enormously influential and continues to be so. I think the way that the global burden of disease work is going to be managed is shifting a little bit. When you start looking behind some of the estimates, you can actually see that they're fairly flimsy, particularly in the countries to our north. A lot of the figures are imputed from surrounding countries. Estimates from Vietnam are based on very little data, for instance. So I think it's beginning to shift so that there's a much stronger focus now on building the information systems that there are in these countries, so that the evidence that's required for planning and for monitoring and evaluation becomes much more stronger. Another reason that I think mental disorders have become more prominent is the clarification of the links between mental illness and particularly the NCDs, and the reciprocal causality that happens between mental disorders of various kinds and cardiovascular disease and diabetes and a number of the NCDs. We know that there is increased risk in both directions. The other is that the focus tends to be on disability in relation to mental disorders, but it's also very much clearer now that for many of the major mental illnesses, there is substantially increased all-cause mortality. So people with mental disorders die 10, 15, some cases 20 years younger than the rest of the population. So, and some of the reasons for this include greater exposure to the risks for NCDs among people with mental disorders, but they also include the fact that people with mental illness generally don't have their physical illnesses well recognised, and treatment and care for those physical illnesses is, I think, everywhere poorer than for people without mental disorders, and that is certainly the case in low and middle income countries. So mortality is also an issue, and the burden of suicide, the figures vary a little bit. They're a bit unreliable because many countries don't have good estimates, but roughly $1 million people a year dying of suicide globally, probably around 300,000 people a year dying as a result of suicide in our own region, with a big proportion of those deaths being among young people, so that suicide is either the first or the second or the third most common cause of death among adolescents and young adults. So there are many reasons why mental health has become more prominent. The focus of those who are working in global mental health, particularly in low and middle income countries, is on a number of areas. The first is to do with investment. If you look at the amount of money spent per capita on mental health related programs and services in high income countries, the average is about $45 per person per year. In a low income country, the comparable figure is 20 cents. In lower middle income countries, it's about 60 cents, and in upper middle income countries, it's about $3.80. So the resources that are available for understanding what's happening in terms of the mental health of the population and then responding in appropriate ways, those resources are pitifully small. And one of the most important limitations in terms of resources is in human resources. The number of people with the relevant skills that are available to respond to this enormous population mental health burden is very low. Take Indonesia as an example, a country of about 240 million people. In Australia, we have roughly 3,000 psychiatrists, thereabouts, for 20 million. In Indonesia, there are 600 psychiatrists for a population of 240 million. Cambodia, with a population of about 14 million now, has about 15 or 20 psychiatrists. And then when you move away from the doctors and nurses, the other disciplines like clinical psychology and social work and so on are almost non-existent in a number of those countries. So the issue of human resources is an absolutely important one, and one of the main challenges in actually developing the capacity to respond to this enormous burden which is associated with mental disorders. And those kinds of limitations or constraints can be found in pretty much all domains. So the human resources limitations are not only amongst those who provide direct services, but they're also those in ministries of health and in other decision-making roles who don't have the necessary skills. There are not enough people. There are not enough people to actually develop the policies, develop the programs, actually develop implementation plans that are going to work, so that those kinds of limitations, in a sense, contribute to the continuation of the problems that have now become very clear. Another difficulty is that there is generally pretty low understanding, what we might refer to as mental health literacy, in the populations of low and middle income countries, so it becomes a kind of a vicious cycle. There is not much understanding of mental health issues, very little understanding that there are effective treatments available, and therefore little demand from the population for mental health services. So it's relatively easy for governments to continue to ignore the mental health problems in the population. The remnants of health systems that countries in Asia, for instance, have been left with are very institution-based. Psychiatric hospitals, many of which are the perpetrators of human rights abuses rather than the protectors of human rights of people with mental disorder. The task of shifting from institution-based, very poorly resourced systems to community-focused approaches to mental health and illness is a massive one, but is starting to happen in some, I think, reasonably successful ways in a number of places. Now, there is, I think, a lot of progress being made in a number of ways. One is, as I said earlier, is that the evidence about the public health importance, but also about the social and development relevance of attending to population mental health, that evidence is growing now, I think, very quickly. We are a lot clearer that attending to the mental health of populations is not only an important public health issue, not only is it an important part of dealing with the four major NCDs, but it's also a major development and social issue. The information, for instance, about the importance of the mental health of mothers in terms of the development and flourishing of very young children has been very compelling, and I think has been very persuasive in shifting attention to mental health. Now, the problems such as low investment, poor governance that I've alluded to very quickly, and limited capacity in a number of areas is beginning to change, and in some ways is changing quite rapidly in our region, in countries like Indonesia and Vietnam, where there is substantially more attention being paid to mental health of populations. The government of Vietnam, for instance, just in the last 18 months or 2 years, has made a massive state investment in developing community-based mental health services, which are going to be managed through the Ministry of Social Affairs in collaboration with the Ministry of Health. This is entirely new, and it's a very new commitment to actually thinking about the social dimensions of mental health and illness, and the requirement that is placed by government on the Ministries of Social Affairs and on the Ministry of Health to actually collaborate in developing these programs is also rather new and in many ways very encouraging. Some of the other positive developments have included really not a massive but a discernible increase in funding for this kind of development. 10 years ago, I think agencies like AusAid would have funded very little, if any, mental health development work at all. They are now providing funding for some, I think, very promising programs. Organisations like the Department for International Development, DFID in the UK, is providing quite substantial funding for mental health systems research programs in Africa and elsewhere. The Wellcome Trust is funding fellowships, senior fellowships in mental health, and so on. Organisations like Atlantic Philanthropies have also put substantial amounts of money into developing mental health in some parts of the world. So the increased attention to mental health is also attracting some increased funding, although the funding is really far short of anything that's going to make a really system-wide difference. In my own view, we'll know that we're getting somewhere in relation to something like mental health development when we move beyond funding from aid agencies to governments actually making applications for loans to the Asian Development Bank and to the World Bank for actually developing their national mental health systems. That hasn't happened yet, but I think we're probably not too far away from that kind of approach to actually thinking about mental health system development. The other major issue just to mention, and then finally in the last couple of minutes or so I want to say something about asylum seekers and refugees, is that we're at the end of the Millennium Development Goals program in 2015. We do have now a pretty clear idea about what the post-2015 development framework is going to look like. It will be very different to the MDGs programs, and there are a number of elements of the post-2015 framework that I think accommodate the kind of interests that there are in mental health much better than the sort of vertical programs of the MDGs program. Let me finish by saying just a couple of words around asylum seekers and refugees. I mentioned that these kinds of concerns that I've been talking about in relation to low and middle income countries apply also to particular populations in our own, subpopulations in our own population. Everybody is aware that the issue of asylum seekers has been one of the most contested areas of public policy for the past couple of decades. There has been what can only be described as bitter division within the community about which way we should go. There have been massive shifts in the way that the political parties deal with these issues, and particularly the massive shifts that the Labor Party went through prior to losing government. What we do know is that the core elements of our policy approach to asylum seekers, particularly boat arrivals, has caused and continues to cause enormous harm. We know that prolonged detention causes both severe and persistent mental health and other problems. We know that it interferes with the capacity to settle effectively. We know that our policy is the implementation of our national policy is actually doing serious harm to some of the most vulnerable people in the world. That hasn't had much impact. The situation has continued to develop in ways that are inimical to those who are seeking our protection. We are in the situation where our policy has resulted in a number of deaths through suicide in detention centres, and most recently to the murder of an asylum seeker. So it's very clear to me that the path that we're on is not going to shift very much in the next, certainly not in this term of government, but we are I think in really deep trouble as a country in terms of how we deal with these issues. One response to this has been that at the University of Melbourne we are in the process of establishing a university-wide refugee studies program. The intent of this is to do research, develop education programs, but particularly to do research that will be helpful in informing the development of policies and programs in relation to asylum seekers that we hope will produce the kind of approach that we can all be proud of. Thank you.
Thank you, Professor Minus, and thank you for reminding us about the burden of mental illness worldwide and its association with premature death. The final speaker in this session is Professor Michael Daub, who is the Professor of Health Policy at Curtin University in Western Australia. and he is going to tell us about non-communicable disease in the Australian context, the progress, priorities and prospects. Professor Daub.
Thanks very much, Jeff, and thanks for the invitation to speak here today. I've had the privilege of working with the AMA on prevention issues for more than 3 decades, so I'd just like to pay tribute to the outstanding contributions the AMA has made to public health over this period. It's enormously to your credit that you've been such stalwart campaigners, regardless of governmental complexions or the strength of commercial and other opposition. And I hope you'll forgive me if I acknowledge especially to my friends in the AMA WA, who've been so active in this area, and in my totally objective and unbiased view, where are we? Yes. Have been the engine room for many of the most important developments in prevention. Was that okay, Paul? Where is he? Right. In particular, though, I want to note your continuing focus on action that will make a real difference, your willingness to confront tough and cynical opposition, and unlike some of my academic colleagues, your interest in making things happen now rather than decades hence. Now, I'm going to speak about the Australian context, and you're familiar with the evidence on the problem. You don't need me to tell you that we face all the developed country NCD problems we've known to grow and love. You don't need me to tell you that NCDs are a massive driver of disease, that 15% of Australians still smoke, 2/3 of adults and 1/4 of our children are overweight and obese, and that alcohol is the cause of not only more than 3,000 deaths a year, but much additional injury, ill health and social disaster, from the patients you see at EDs to the victims of domestic violence to children with FASD. So I'll focus on what we need to do, why we aren't doing enough of it, what we've learned about generating change, and some of the things the medical profession can do, especially at the policy level. We are, of course, one of the longest lived and most affluent populations on Earth, and some of our NCD concerns arise because of those factors. The irony is that we know so much of what actually needs to be done to prevent many of the diseases of affluence. Like others here, I strongly support more health and medical research, but research is useless unless somebody does something with it. Just one example. Research showed us with certainty in 1950 that smoking's lethal, and the same in 1981 about passive smoking. Yet 64 years later, we still have 15,000 deaths annually, and 1 million Australian deaths since 1950. From a totally preventable cause of death and disease. So what are the main preventable causes of not only so many NCDs, but a raft of related health, social and community problems? Well, nothing new here, especially after Rob's talk. There are 3 standout areas that affect the community as a whole and cut across assorted cancers, CVD, respiratory disease and diabetes, and bring massive costs to the community. So clearly we have tobacco, we have overweight and obesity, and we have alcohol, and that actually comes from a Jim Beam on campus Facebook, university Facebook, or we have them in combination. And as elegantly described by Teresa Marteau in this week's BMJ, the main vectors of disease in the 21st century are tobacco, alcohol and processed food. Now, there's always room for argument among economists, but from the various estimates we can conclude that the total cost to the community of those 3 are at least $70 billion a year. Ironically, the government actually subsidises the alcohol and processed food industries, and it also derives close to $15 billion a year from taxes on tobacco and alcohol. A good bucket, you might think, from which medical research could be funded. There are also some... an extra 30 seconds, please, Maurice. Thank you. There are also some groups that are at special risk. The life expectancy for Aboriginal people has been well documented and reported. In addition to their many other disadvantages, Aboriginal people smoke much more than the rest of the population. They're substantially more at risk of alcohol-related harm, they're more likely to be overweight or obese, and they're more vulnerable to predatory promotion. The Close the Gap program has made some inroads, but the life expectancy gap remains at over 10 years and is a formidable and shaming challenge. There's a further disadvantaged group, less widely reported and publicised, fewer programs and less action, but also a massive life expectancy gap, much of it attributable to NCDs. And we've just heard a bit about that. For people with mental health problems in Australia, the life expectancy gap's around 14 years. 12 for females, 16 for males. And let me stress, that's just for people in contact with mental health services. For those with more severe problems, the gap's much greater. On the basis of international evidence, 20 years and more. And the gap is increasing, and around 80% of it is preventable, mostly NCDs. Now, no one pretends that addressing problems around mental health are easy, and there are always persuasive reasons for not acting, but this is an area where our health and mental health systems have been almost completely missing in action. The physical health of people with mental health problems is constantly overlooked. There's no national outcry about the need to close that equally shameful life expectancy gap, and there should be. Let me take smoking as an example. Around 40% of smokers now are people with mental health problems. Like other smokers, 1 in 2 will die because they smoke, as well as being affected by a range of tobacco diseases along the way. Like other smokers, most want to quit. Like others, most can do so with appropriate encouragement and support, but with some honourable exceptions, that action to help and support them is virtually invisible. Okay, to the big three: tobacco, alcohol and obesity. Here's the great irony. We know so much about what needs to be done for each of them. There aren't any magic bullets for individuals, but we do know most of the actions needed over time at the population level. A few years ago, the federal government established the National Preventative Health Task Force to develop national strategies around these 3 areas. Rob was the chair and also chaired the Alcohol Committee. I was the deputy chair and oversaw the Tobacco Committee. I've always felt that decisions about chair and deputy chair were made on the basis of height. We did all the things that national commissions of this kind do: research, consultations, meetings, discussion papers, submissions, and we produced a thorough report setting out clear strategies to deal with preventive issues across the board, and tobacco, alcohol and obesity in particular. And it's worth reflecting on this, because governments, especially in prevention, have a nasty habit of setting up inquiries, submissions and reports that may sound valuable but are a brilliant stalling device. By the time the process has run its course, ministers have moved on, governments have changed, the public pressures that led to the government deciding how to do something are no longer so high profile, the report gets a bit of publicity, there's then a further delay while the government considers it, and then nothing much happens until there's more public concern it's time for a new report. So in writing our report, we were very conscious that it would have to stand the test of time. We don't need new reports and inquiries. We know what needs to be done, and here we were saying is our recipe. So what was common to all 3 areas? First, the magnitude of the problem, the harms to individuals, the impacts in healthcare and other costs, and for tobacco and alcohol, the direct harms caused to non-drinkers and non-smokers. Then community concern. Survey after survey shows that our community is worried about these issues. They're worried about alcohol, from violence to drinking patterns among children and young people. They're worried about the impact of smoking. They know about the rising tide of obesity and its consequences. But third, while there's of course ample evidence to justify those concerns, we actually know that community is nowhere near as fully informed about all the various direct and indirect harms of alcohol, obesity, and even tobacco. They're still not fully informed. Fourth, in common, we all need, for all of them, a comprehensive long-term approach encompassing a combination of public and other forms of education, regulation, taxation, health professional engagement, and special programs and support for disadvantaged groups. Fifth, we need to recognise that health departments, systems and professionals are not the only key groups that can and should have a role in implementing the approaches we need. Just in government, it's not just health. Treasury, industry, agriculture, justice, education. I might say it's stunning that the new national curriculum, the new national school curriculum, prioritises the arts but doesn't prioritise health and physical education. And other departments too. Sport, which should support our aims but seems to be supporting alcohol and junk food sponsorship as a higher priority, and so many other areas. So health is not the only agency that can do something. Sixth, as Rob's shown, there are massive global and national vested interests determined to promote the products that lead to death, disease and injury from tobacco, alcohol and obesity. And seventh, those vested interests and their fellow travellers will do everything they can to oppose and undermine measures that actually make a difference. Let me give you one personal anecdote. When I was in the UK in 1973, starting to make a noise about tobacco, working from the Royal College of Physicians, the chairman of the chairman of an major international tobacco company, which shall be nameless, came up to me at a meeting and generously offered me funding generous funding to work on any campaign of my choice other than tobacco. So they'll do everything they can. Okay, so we reported. We recommended this is a slow loading slide because it's Rob's. We recommended achievable we recommended achievable targets for Australia, and we thought they were achievable. We're getting some with tobacco, not really with the rest. I'll come back to that. And then we recommended specific, comprehensive approaches for each of the 3 areas. And I won't take you through them all. It's that mix of public education, regulation, a range of other measures, support for disadvantaged groups, proper labelling for each of them, not just tobacco, and so on. So we made those recommendations for all 3 of the areas. So they're all comprehensive and all doable, and I might add, all consistent with AMA policy. So what happened? With one exception, the government took its time, sent the report out for further comment and discussion and consultation, produced a further report on our report, and they all sit on shelves. Now, the one shining exception, in fairness, where ultimately with all party support, the government pretty much accepted all our recommendations, was of course tobacco. And they went with our recommendations, including tax increases and plain packaging, despite the most ferocious campaign I've seen in 40 years of working on tobacco for the tobacco industry. But after all of that, they and we, and you, took on the vested interests, and we won the battles. To its credit, the then opposition, now government, has maintained the focus on tobacco. One ray of hope amidst the distressing prevention cuts in the recent budget is, along with regular tobacco excise increase and support for plain packaging, the government's committed to continuing funding for strong tobacco media campaigns. So we're still in a tobacco war, and there are still major challenges, but in this country at any rate, we're winning and we deserve an A rating. With alcohol and obesity, the picture's different. We get an A for magnitude of the problems, D if we're lucky for action. In alcohol, along with manifest public concern about alcohol and violence, binge drinking and the rest, various groups around the country have been raising the temperature and calling for the kind of action, this is from one particular event, calling for the kind of action that's recommended in the Prevention Task Force report. The AMA, both federally and in the states, has been prominent. Between us, next slide please, thank you. Between us, we've established a National Alliance for Action on Alcohol with close to 80 member organisations, and there are now similar coalitions in almost all jurisdictions. This is the WA one, but we also have New South Wales, Victoria. I think pretty much all the jurisdictions now have coalitions of this kind, so nationally and state. There's been some action in some states, but the truth is that the alcohol industry still dominates. The brewers, distillers, winemakers and hotels have won all the major political battles. We still don't even have decent warning labels about FASD, let alone the rest. And tonight, Woolworths is launching Duff beer, would you believe? Straight from The Simpsons. With obesity, the position's even worse. Almost every day we see more headlines and stories about obesity or related issues, but nothing serious is being done. We have generations growing up in a world dominated by cars and screens, for whom processed food is the norm, with junk tastier and cheaper than healthy food, households where time for food preparation is hard to find, and public health groups powerless in the face of global as well as national massive promotional, PR and lobbying budgets from the food and alcohol industries. So the picture's depressing. But those obstacles are similar to those we faced with tobacco from the times when 75% of Australian males smoked. 75%. Tobacco promotion was everywhere, and the tobacco industry was all-powerful. My colleague Satvinder Dhaliwal and I put this slide together very light-heartedly a few years ago. We thought we were being light-hearted, but we're now ahead of that. And we're seeing really encouraging trends in kids as well. So we absolutely must keep the pressure up, but we've even beaten the industry on their most treasured ground, and we're winning here, if not overseas. So what have we learned from tobacco that we can apply to the others? First, overnight success takes time. It doesn't happen overnight. We've got to be impatient, we've also got to be patient because the measures will come. We're building up the temperature on alcohol. I think we will see moves there. I'm incredibly pessimistic about obesity. I think we will see moves on alcohol from similar approaches. Second, we need to work in coalitions. There are so many health groups concerned about those issues. In isolation, they may not achieve much. Working as coalitions, we can be much more effective. And the AMA has been a crucial figure in those coalitions so far. We need a consensus approach. Again, so important. In pressing for action, we all sing the same song. In tobacco, we've had an absolute consensus approach since the mid-70s, when we put together guidelines for smoking control for the International Union Against Cancer, and then later the same guidelines for WHO. So we've had, scratch any of us, we all sing the same song in tobacco. We need to do that in the other areas too. Again, we're getting there on alcohol, I think not on obesity yet. We need comprehensive policies. We shouldn't get caught in the trap of looking for one magic bullet. These are all major community and behavioural problems requiring a range of approaches, not just one. And we shouldn't be put off by industry or bureaucratic arguments. We shouldn't try something just because it's never been done before. Splendidly described by Cornford and loved by bureaucrats as the law of the dangerous precedent. And from that law it follows that nothing should ever be done for the first time. We also need clear messages, and that's hard. In the UK, a splendid report was produced for the government. They were commissioned, a foresight group, terrific group, to show the government with clarity what needs to be done on obesity. Where are we? So they came up with the answers. And if you were a minister, you'd just go straight with that, wouldn't you? So we need clear messages that we as health communities and health organisations can present to our decision makers and to the community. What else have we learned? Well, something the AMA is pretty damn good at. We need to understand governments and policy and the way governments work. We shouldn't go to state governments for federal issues, and we shouldn't go to people 2 days before the budget expecting a decision when the budget's been finalised a while ago, and so on. We need to understand governments and policy, and we also need to work with the media. That's so important to ensure that our messages are well presented. We need treatment and research. Of course we do, but they're not prevention, and we should stay right away from either-or debates. It's not a question of either prevention or treatment and research. We need both, but we shouldn't pretend that treatment and research actually are prevention. You know, the figures show that about 2% of our national health spend goes to prevention, but it doesn't, because a whole lot of that's actually treatment too. What else have we learned? We've learned to curb industry marketing, and we've learned to oppose and expose the opposition. Not one of the most easily seen slides, I'm sorry, but this is a slide that shows how successful that's been with tobacco. Tobacco, if you're looking, is now right at the bottom. It is the world's least reputable industry because we, between us, have opposed and exposed them so effectively. We've learned that advocacy works, and we've learned that the AMA has a crucial leadership role. I might say I'm not saying that just because I'm here, I say it elsewhere too. AMA is absolutely crucial. So what can the AMA and its members do? There's scope for action at all levels. There's scope, of course, for action with your patients, even though co-payments may now deter some of those who would have come to you for help with smoking, alcohol, or overweight and obesity. But there is scope for action with your patients. There's great scope for action at the community level. You've got great capacity to influence others around you, to make them aware not only of the problems, but of the policy issues around them. You can take leading roles in NGOs. You speak with politicians and other decision makers. You can speak with the media. To go back to prehistory, when in WA we were pressing for tobacco ad bans about 25 years ago, the AMA ensured that its members sent cards to politicians every time one of their patients died from smoking. It had a tremendous effect. You can have that effect. There's an enormous scope for action by state AMA branches, and I know that many of you have done that. State and territory governments make many of the key decisions in these areas, from school education to advertising spend to smoke-free areas to liquor licensing and control. They worry about local pressure, local media, local AMAs. I can tell you from my own experience as a State Director General of Health for a few rollercoaster years that the AMA worries state politicians in ways that no other external groups do. And you have a similar impact at the federal level, but more than this, you can help to set the agenda as you did on tobacco and have recently been doing on alcohol. You're also an organisation with the credibility and clout to take on the vested interests that oppose action. Tobacco companies that still try to cast doubt on the evidence and oppose action, a processed food industry for whom, and I quote directly from notes made by a colleague at an industry forum, public health is enemy number one, and an alcohol industry that makes submissions to government arguing that industry interests should take precedence over the well-being of the community. So my final quote is from the 1980s, but I think summarises our challenge as well. This is from a speech I found in confidential tobacco industry documents that we can now get, and it was from an internal conference from the then chairman and CEO of the Philip Morris Company, which at the time also owned the massive Miller Brewing and craft food companies. So tobacco, alcohol, and craft food. And what did their chairman and CEO say? He said, "Many of the threats to us, Philip Morris, arise from concerns which have lost touch with common sense and reality. People and politicians do need causes. And in a world which is generally more peaceful and affluent than ever before, there's a shortage of big causes. That's why we hear so much about really rather little causes. Smoking, drinking, dietary hazards. So the vectors see the NCDs as really rather little causes. We've learned from our tobacco experience that they can be turned into really rather big causes, but that only happens with AMA support and leadership. Thank you.
Microphone. Yeah, thank you, Professor Daub, for that absolutely brilliant run-through of what the challenges have been in public health over the last few decades. And also, thank you for acknowledging the role of the Australian Medical Association. Now, thanks to the speakers, we're now back on track with the planned 15 minutes of questions before afternoon tea. I just need to let people down here know that the question system up here isn't actually working. But so feel free to post your questions there. The purpose of today's session is to inform the AMA on the sort of directions that we might follow in terms of public health and global health. And perhaps while the question system is getting up, I could just sort of start by perhaps a question to Professors Daub and Moody, which is around the rather controversial area of public health organisations and advocates engaging with the industries. I know that there are many who feel that that is futile and a waste of time. Just be interested in your view, and in particular perhaps not mentioning any organisations, but you might think of DrinkWise.
Look, I take what I think is a stock standard public health position, and is the position of the World Health Organization Director General Margaret Chan, which is that we don't engage with those industries. We've seen it with tobacco. The tobacco industry ran education programs, and then there was research showing very clearly that those education programs they ran not only weren't effective but were counterproductive. They ran phony programs, programs aimed at children that don't get anywhere, but sometimes even seem designed to normalise smoking as an adult behaviour, all that kind of thing. Same is going on with the alcohol industry. These are industries that spend billions of dollars encouraging people to use their product. That's their duty to their shareholders. There's tiny little bits of soft activity they do that is designed to show them as having what they call corporate social responsibility. We've recently seen on the Food Star rating site, and that's now history. I gather it will go back up again, which is good news. But we've recently seen there again the food industry, opposing even the start of a serious public health communication. So, look, very clear. Our job is to promote public health messages. The people who should be presenting public health messages to the community are governments and public health authorities, not the people with a vested interest in selling as much of the product as possible. And I might just finally add, we've had an enormous joy with tobacco in recent decades. Thanks to litigation in the US, we have access to millions of confidential tobacco industry documents, some of them applying to the alcohol industry too. And if you thought there was need to be cynical, those documents double and treble that need to be cynical. So the cynicism model of public health.
Want to add anything?
Just quickly to back up what Mike was saying. I mean, 2 points. One is that there's very strong evidence that industry funding biases the research outcomes, and therefore, universities, we don't think should be taking money from tobacco industries, nor certainly from alcohol or from the junk food industries, because it simply does bias the research. The second point is, having sat on the, and Mike knows as well, on the National Preventative Health Task Force, where we had a member of the Australia Food and Grocery Council on the council, and having members of the alcohol industry on the subgroup, they absolutely skew discussion. They will do everything in the discussions to make sure that they try and water down the recommendations, try to divert attention. So it's an active form of internal opposition, if you like. We agree we should engage with these industries, but it's not around the policy, it's around implementation of policy.
Okay. Let's go to a question from Chris Milross, addressed to any of the speakers. Could you comment on the balance between effort and cost required for upstream approaches to non-communicable diseases, that is prevention, compared to the need for potentially life-saving treatments for these same conditions?
Well, we're actually doing a study on this right at the moment, comparing, for example, government subsidy or government investment in public health approaches to tobacco compared to, for example, government investment in pharmaceutical agents such as Champix and Zyban. At this stage, we think the cost effectiveness is probably about 100 to 1 in favour of public health, whereas the actual investment is about 1 to 100. So if you want to do your maths, it's in many cases a significantly important investment in upstream approaches. Another area where, unfortunately in Australia, our investment per capita in skin cancer control, which has been enormously successful, is a third to what it was in 1980. Now we're investing in extremely expensive, in a sense, treatments which provide treatment for those with end-stage cancer. If we could have only invested so much of that money in upstream approaches that we know work, means that so many of those people would never have got melanoma in the first place.
Okay, and the next question is from Wayne Hurdy. Australia has some of the toughest motor vehicle legislation in the world and very low rates of death and injury from motor vehicle crashes. Even in the USA, basic safety such as seatbelts and motorcycle helmets are flagrantly overlooked. But in the developing world, not only are safety measures such as seatbelts virtually non-existent, but economic pressures lead to an environment of cheap vehicles and poorly maintained vehicles and roads. I wonder if the speakers could comment on the price that developing countries must be paying for trying to implement transport machinery fundamental to economic growth.
Rob, do you want to start with that?
Yeah. I mean, having ridden from Ho Chi Minh City to Da Nang on a back of a bike without a helmet. This is a long time ago, but not the safest thing to do, but because simply no one was wearing helmets. But it is, I mean, we know that in many countries now that are starting to implement road trauma, it's actually a very cost-effective way of reducing premature death. But it is about having a whole range of functioning systems, not the least of which is having an enforcement system, which, you know, the frontline people actually in road trauma in Australia are the police, because they're the ones that actually, in a sense, those that help determine and encourage our change in behaviour. But it's been a great combination between police, engineers, road engineers, health people as well. I think, Harry, you know, in Vietnam, I mean, it's a big challenge, but gradually many of the countries are really coming to terms with the need to have a population approach to road trauma.
Can I just... Sorry, Harry, did you want to come?
Just specifically about Vietnam. I was in Hanoi on the day that the helmet changeover happened. So the day before, nobody was wearing a helmet. The day that it started, everybody was wearing a helmet. But it's also, and now it's absolutely mandatory. Everybody wears a helmet. You very rarely see anybody riding a motorbike not wearing a helmet. And it's interesting, the role of an international philanthropic NGO, Atlantic Philanthropies, was largely responsible for actually mounting the campaign and getting that policy change to happen.
Can I just make a couple of quick points out of that? The first is, it's absolutely right. Australia does do better in road safety than developing countries like Vietnam and the US and so on. There are two points I want to make out of that. The first is that Australia actually, you get a bit of doom and gloom on the prevention front sometimes. We do have a terrific record as leaders in prevention. There are so many areas where Australia has been a leader. We've shown the art of the possible. And relating back to an earlier question, it doesn't cost an arm and a leg. It costs primarily political willpower, or political will. The second point I want to make out of this is that with road safety, seatbelts, a whole range of other issues, just as with tobacco, just as with other areas, when the suggestion of these measures, seatbelts is a good example, when that comes up, the ambassador talked this morning about folate fortification, where I was heavily involved in the campaign. When that's raised, you get all the arguments against, all the arguments why it's going to be impossible, all the arguments why nobody will do it, all the arguments why the sky will fall in and it'll be totally impracticable. And then you find that it happens, you get legislation, and it just works. People observe it. Of course you need enforcement with some, but it works, and it's just seen as part of the culture pretty quickly. So I think there's grounds for pessimism in some areas, but a recognition too that Australia can lead, and that then other countries do follow our example, just as they're going to be doing on tobacco plain packaging.
Okay, and a question from Dr. Rudy Lopez, again to any of the speakers. Any comment on the idea of having a differential private health insurance rate for those who smoke or drink or have a sedentary lifestyle? How could this be policed?
Oh, God. Do you want me to dive in? I actually don't like it, I'm sorry. I don't like it for all kinds of reasons. First of all, smokers are probably the least likely people. The smokers are people, apologies if there are any here, but there aren't, because smoking is essentially a behaviour for people of lower economic standards these days, lower and lower educational attainment. It's just what the data tell us. Of course, there are exceptions, but by and large, smoking is now a behaviour of disadvantaged groups, primarily. As I said, 40% of smokers are people with mental health problems. We've got high smoking in Indigenous populations. So first of all, I don't see what that's going to do. And second, I think the idea of, if you like, penalising people for their health behaviours is all wrong. You don't stop somebody coming into an emergency department because after a crash because they've been drink driving and so on. So I think penalising the individual there is where I stop.
I mean, I also think the point about if you take weight, for example, losing weight individually is actually really tough. We put it on collectively, we probably have to take it off collectively. And until we change the environment in which we actually live in, it's very hard to do that. And unfortunately, we have such an obesogenic environment at the moment, whether it's the vending machine or whether it's the constant promotion, sponsorship of sport, where you have Australian kings of sport, all of whom are major ambassadors for junk food, let alone alcohol and gambling. These are the sort of cultural shifts that we need to make. And as Mike's pointed out, we need the AMA to be out there leading on these.
Okay, and a question that might need to be the last one is to Professor Minus. It's from AGM, so you'll know who you are. What evidence is there that indefinite mandatory detention of asylum seekers and the manner of their detention causes or aggravates psychological injuries and mental illness?
The evidence that exists is very strongly in support of that assertion, but it has to be said that the evidence is not very extensive. And part of the reason for that is that there has been opposition to research in this area. I was on the Ministerial Advisory Council for almost 12 years, In the first meeting of that council, we said that there should be long-term research within the detention centres. That was opposed at every point, and nobody was ever given permission to actually do research in the detention centres. So the quality of the research is less than it should be, but the research, such as it is reasonably clear.
Okay, well, look, thank you for that short answer. In view of that, perhaps a quick one here to Mike Daub. Question from AGM. Should we have a fat or sugar tax like the successful one on tobacco?
Look, I think that's a complex one. There's no question about the role of tax in terms of tobacco and the role of tax in terms of alcohol. Should we be taxing certain products more heavily, certain junk food products more heavily? I think probably we should, because I think there are mechanisms that can be introduced, but I think that's got to be pretty carefully done. And I maybe don't go quite as far as some of my colleagues here, because I do have concerns with some of those products that, by and large, they're the staple for people of low socioeconomic status and so on. So I think probably over time, but it's got to be very carefully done.
And I think you can start with a tax on sugar sweetened beverages. I mean, that's the place to start in the area. I think is absolutely fundamentally it's completely unneeded calories, and is just putting weight on around our belts collectively.
Sorry, I should have said the soda tax is fantastic. For the rest, I have a worry.
Yeah.
Okay. Look, thank you everyone for your questions. If I wasn't able to ask the question, please feel free to refer that to the speakers during the tea break. I'd like to thank all of the speakers for what has been I think a really stimulating and thought-provoking session in terms of the potential impacts and current impacts of non-communicable disease, both in Australia and their effects on global health. So please join with me in thanking the speakers.
Ladies and gentlemen, I'd echo Professor Dobbs' appreciation and thanks to the speakers for a splendid session. We've come to afternoon tea and we'll reconvene at 3:45. That is for the admission of the awardees to the Roll of Fellows and the AGM. The important point is that you need to sign in during the break to receive a voting card for the AGM. You'll receive a yellow card as a delegate, and if you're holding proxies, you'll receive an orange one as well. The AGM is for members and for staff of the AMA, both federal and state, and for the guests of the Roll of Fellows. Non-members and guests and other observers don't attend the AGM. So sign in during the break and reconvene at 3:45. Thank you.